So I think we are ready now to start our webinar today. Hello, everybody. I am Hazem Khamis, Professor of Cardiovascular Medicine, Egypt. I'm the General Manager of Wadi Nil Hostel. It's an honor and a pleasure to meet my friends, my colleague, Professor Alberto Cremonesi, the eminent interventional cardiologist and endovascular interventionalist from Italy, Professor Sherif Assam, Professor of Vascular Surgeon and Endovascular Ain Shams University, Egypt, Dr. Sherif Kirdawi, Associate Professor of Vascular Surgery, Endovascular, Helwan University, Egypt, and the Director of Endovascular Cath Lab in Wadi Nil Hostel. Of course, I would like to thank Abbott Vascular for their support and Icon Company, the company responsible for the transmission. I need to introduce the format for our colleagues. The format will be like interactive session. We'll have first 10 minutes for Dr. Alberto Cremonesi to give a small talk about the interventional endovascular intervention in the COVID area in Italy. Then we will have a case of SFA popliteal intervention by Dr. Sherif Assam. We'll see the case, the clinical scenario, the CT angio, and we'll stop. And then we'll discuss with our speaker and the moderator what is the strategy to treat this case. And of course, you have the possibility to send your questions to the moderator to respond and to answer these questions. And then Dr. Sherif Assam will continue to show for us how he treats this case. And then we'll stop and again discuss with our colleagues different opinion, different strategies, and we will finish with take-home message globally and from this case. So I ask Dr. Alberto Cremonesi, our colleague and the eminent interventional interventionalist all over the world, and one of the course director for the BCR and the BCR Peripheral in Paris and in Istanbul. So he will start his talk. Alberto.
Oh yes, let me share the screen with you. Once again, is not that simple, but I will succeed. I don't know why is.
Professor, open your presentation.
Okay, I can share. No, can you present for me? Because I don't know why, but something is not working in the right way.
Go to the Zoom, yeah. And then you will find the share screen button.
Yeah, but I am there, but I don't know why I do not see my it was open, but I cannot share. Do you have my presentation? Please do it. Because
okay, you have
here we are.
Okay.
Here we are. Sorry for this inconvenience. Now I go immediately. So, dear friends and all the participants to this great round table between expert and all the participants, just to share my experience, which was really a huge experience during the last 3 months, about what happened in the peripheral world related to the pandemic. The pandemic really was present all around Europe and the industrialized countries. we had a huge diffusion, mostly in the northern part of Italy. At the moment, we count around 30,000 dead patients for the COVID. In the last 2 weeks, I have to say that we are in the decreasing phase, and fortunately, we have to think that in the last 2-3 weeks, we will recover completely. So what happens about our standard peripheral practice during this pandemic? Interestingly, we continued obviously to do any kind of peripheral interventional procedure, but mostly emergent interventional procedure. But at the end of the story, I have to signal that the COVID-19 pandemic reduced about 60% of presentation of patient presentation to our hospital for the standard peripheral practice. Why did happen this kind of situation? For a simple reason that the COVID infection is not only an important and hypoxemic pneumonia. COVID infection is related also to dysfunction of endothelial cells and the cytokine release syndrome. And we had actually a situation where we found hyper and hypocoagulative status of the patient. And interestingly, in these 3 months, we had a lot of something of disease completely rare in the past. For example, systemic vasculitis, acute limb ischemia, deep venous thrombosis, pulmonary thromboembolism, and diffuse intracoagulative situation. This situation for COVID was really well explained, mostly for the coronary vessel, where the cytokine storm and the inflammation related to COVID determined plaque instability and rupture, but also we have seen a lot of myocarditis. Less defined is what happened in the peripheral situation, but I have to show you what we had to treat in these 2 months mostly, not the standard peripheral practice, but for example, related to this hyper or hypocoagulative status of the patient with COVID, we had many spontaneous intraparenchymal bleeding, and the only way to really solve the problem was to embolize the feeding arterial vessel, as in this case, where we had to fully embolize an important branch of the hypogastric artery. Another important part of our interventional procedure were dedicated to vasculitis, and this kind is an acute aortitis in a very diseased aortic segment. You see in the CT angio, but you see here a huge penetrating ulcer, acute penetrating ulcer, completely resolved with the implantation of an endoprosthesis. So you see that something in the treatment of our patient was completely different, but also was completely different the way we had to work in our daily practice. We had to wear personal protective saving tools in the cath lab. You see here Antonio Micari working with 2 nurses with protective eye protection, isolation gowns, disposable face shield. And also, for every patient who entered our cath lab, we had to disinfect the lab itself, and we used pulsed xenos ultraviolet systems, which is very fast but very effective for the COVID. Also, the same situation was present in all the wards and intensive care unit, and this was the way we had to treat and to take care of our patient. You see that all the staff, the nurses, the doctors had to wear isolation gowns and disposable face shield. Otherwise, you got infection, no way. Where we are now, I told you that in the last 2 weeks, we had a partial resolution of the infection. And now we are in the phase that, fortunately, we have 2 tracks in our big hospital. One is for recognized COVID-free patient, and the other track, parallel but completely different track, completely different building for a recognized COVID-infected patient. The real problem today is to understand, understand the undetected COVID-infected patients who are presenting to our hospital. And the only way to do it is the swab test, which is not easy to do. And probably for this reason, this is the major challenge. But I want to conclude very fast this experience we had in my hospital, which led us to think that the healthcare system of the regions where we had the major distribution of COVID, healthcare was really tested by the pandemic. And what we have learned, what we realized is that now we are trying to build the next normal for our healthcare, but probably this new normal will look nothing like the normal we leave behind. And my personal concern is that in the future, any kind of interventional procedure probably will do in a different way, mostly for the access to the patient to the treatment, for peripheral, for coronary procedure, as well for TAVI, for example, or any other structural heart intervention. Thank you very much for this talk, which is very close to my heart.
Thank you. Thank you, Professor.
Thank you.
Thank you, Alberto. Thank you very much. I think we can conclude from your talk the safety of the physician and the medical practitioner in the hospital and the cath labs is very important. The only way is to treat all the people as a COVID patient. Either they are positive or negative, you must have all the protection for the staff to treat those patients. Thank you very much. For sake of the time, we'll go immediately to the main presentation today, the SFA popliteal intervention case. So Dr. Sharif Assam will show his case and will make this as usual for the interactive discussion. Okay, Dr. Sharif.
It's my pleasure to be participating in this scientific, interesting webinar day. And my name is Sharif Assam. I'm a professor of vascular surgery at Ain Shams University in Cairo. And we can start now with this presentation. Please bear with me during the presentation. That's a femoropopliteal endovascular intervention. This is the patient's presentation. This is a 78 years old male, diabetic, hypertensive, ex-smoker. He has a history of coronary artery bypass grafting. He presented with the toe gangrene, the fourth toe of the left leg, left fourth toe gangrene, with rest pain, and his ABI was 0.2. That was his CT angiography, and as you can see, it shows quite good amount of calcification at the aortoiliac and in both common femoral arteries, as well as in the midis. He's complaining from the left leg, so I'll focus on the left arterial system now. As you can see, the common femoral artery heavily calcified, in here calcification in the SFA, and then below the knee, there is a nearly attenuated P2 segment and heavily calcified P3 segment. And this is another view for the sagittal view for the CT angio to evaluate the amount of calcification. As you can see in here, that's the calcium in the common femoral artery, because that's what we are going to see now during the angiography very clear.
Okay.
Now, axis.
We'll stop here and we can summarize the case. He is a male patient with all the risk factors for vascular involvement, diabetes, hypertension, ex-smoker, coronary artery bypass surgery, critical limb ischemia with gangrene, and the CT angio shows heavily calcified arterial bed from the distal aortic bifurcation up to the distality, with the symptoms mainly left leg, and we have a total
gangrene.
The SFA at B1 segment, but I think it is short segment of effusion if I look very clearly for the CT. The issue now, we have a very heavy calcified vessel on both sides. So when you decide to do for this endovascular treatment, we must discuss the site of the puncture, the axis, because the calcification, one of the major enemies for the endovascular treatment. So, Alberto, what do you think about how to choose the axis in this case?
But I think that this CT angio is very important to be evaluated in order to plan our procedure, because all of us know that we have many ways to go toward the distal leg. We can go antegradely, we can go in crossover, we can go from retrogradely, we can go from many ways. Now, looking at the angio and the calcified lesion and the calcium distribution also in the distal aorta and the area bifurcation, I have to say, firstly, almost impossible to go antegradely ipsilateral. Also, the contralateral approach in crossover, I think that we will see from the direct angio, but I don't think this accessible from a contralateral and crossover technique.
Contralateral access was pretty, I mean, when we started the procedure, just having a look at the contralateral common femoral artery with the duplex scanner or the ultrasound, it looks quite heavily calcified. So we were not happy to go contralateral because of the heavy calcium load in the contralateral common femoral.
I fully agree with you. I fully agree with you. And so from this perspective, we cannot use the contralateral or the antegrade puncture, ipsilateral antegrade puncture. And now we have to decide which other access is doable in this kind of patient. And to be honest, I do not see many other ways. So, and I think that we
Alberto,
have to go from above.
Alberto,
Yeah.
we are discussing all the axes. If you are the operator and the patient is on table and you put your plan to do the case, what is your strategy? If you are the operator, what axis you will start with?
I tell you, in this specific case, and this is what we do in our general practice, when we see so diffuse calcification, we go from radial or brachial left, generally, just to have a very clear possibility to study the common femoral and the bifurcation, and also to study what is the situation. But we start with radial or brachial. Consider that we are interventional cardiologists. It depends on the dimension of the patient, but for me it's the same, radial or brachial, and then we start the discussion about what to do in this specific case. Because another good point, if I look at the distality of the left leg, actually I have to say that the posterior tibial artery is quite good, and also we have to think it over to this kind of anatomic situation. Interesting vessel, that one. Okay, anyhow, I would start with the left radial or brachial.
Well, that's what we chose. We have chosen. We chose to go brachial, and we were planning to that we might need to complement this brachial axis with a retrograde axis, because going, yeah.
Please stop. Sharif Kirdawi, what's your opinion?
Yeah, it's a very interesting angiogram, but I think we have to combine the clinical examination for this patient. What I mean, if I can feel a good femoral pulse, this means that it might...
No, it was not palpable. No, it was not palpable.
This is very crucial. If I have a good femoral pulse, this might be an exaggerated image of the CT angio. But if I cannot feel the femoral pulse, this means this heavily calcification is fully abundant in this patient. But regarding the transbrachial approach, mainly the transradial approach in our intervention is not applicable that much, especially in distal SFA and P1 segment, because we don't have this much long tools to go through transradial approach. But transbrachial approach is very applicable, and we use it a lot in this kind of situation. But regarding this kind of patient, we have patient doing cabbage. So a left transbrachial approach is a questionable in those type of patients. So we have to ask the patient about the details of the cabbage procedure he did, and which the type of artery he have consumed for the cabbage. And if so, I will choose a right brachial approach if this will might hinder his cabbage procedure. But the right transbrachial approach is much longer than the left one. So the same situation will be difficult again to go all through the vessel from the right brachial approach. It's a very difficult situation, but we have to you know, tailor every patient according to its situation.
Okay, we have a comment from the attendees. They recommend to do left radial approach. One of our colleagues recommend to do the axis via left radial approach. So we show for our colleague the brachial approach, radial approach is feasible according to the length of the patient, the length of our tools and our equipments in the cath lab. The second point, who is doing the brachial puncture. The brachial puncture may be a very easy puncture, but need a very meticulous puncture for the safety of the nerves, for the safety of the limb. Who do the brachial puncture must be very expert to do the puncture, very expert to do the compression after finishing the procedure. So I think we can go, Sharif, to what you did for the access.
Yeah, as we mentioned in here, that the access was planned to be primarily transbrachial, to be complemented with a retrograde approach. That's because 2 points. The length of the tools is sometimes not sufficient to traverse the whole distance from the brachial down to the popliteal and tibial vessels. And the other point is to deal with the heavily calcified occlusive lesion, the lower SFA and P1 segment coming from far away from the brachial axis might sometimes be pretty challenging. So the plan was a brachial axis to be complemented with a retrograde axis. And for the retrograde axis, we were nominating the anterior tibial artery.
Brachial right or left?
Brachial left brachial axis. Because yeah, he had a coronary angiogram recently with radiologists, and we were happy with his CABG, so there was no problem regarding this point. But we were planning to go brachial and retrograde. So, and the retrograde, we have chosen the anterior tibial artery. Why we have chosen the anterior tibial artery? We do the access under ultrasound guidance. So even if the anterior tibial looks pretty attenuated or not going down to the foot, but we can still access the anterior tibial with a direct ultrasound guided puncture. In order to keep the posterior safe, we usually pick up the best artery going to the foot and try to keep it safe away from our manipulation as much as possible. So the plan was a through and through intervention through the brachial and retrograde anterior tibial puncture. Is that okay?
Okay.
Proceed?
Yes.
Yeah.
Now, coming from above the brachial, and this is the first angiography in here. As you can see in here, that's the head of femur, and we noticed that there's something going on here. So we took another image further on the head of femur, and as you can see in here, that's the calcium in the common femoral artery, and that's the bifurcation into SFA and profunda, and you can here appreciate the amount of calcium in this area. So further down, we took another angio, and that's the occluded Hunter's canal, SFA at the Hunter's canal, occluded popliteal artery, and that's a direct injection showing the occluded Hunter SFA at Hunter canal and the popliteal artery as well. And that is the very faint runoff. If you can see in here, very faint refilling of the P2 segment and continuing down P2, P3, and posterior tibial.
Okay, Sharif. Alberto,
yeah.
which wire you will start to puncture this occlusion? Which wire? What you prefer?
General, the occlusion. So you say. Let me understand exactly. You are speaking about which lesion? So
we started with the femoral lesion. We started with the common femoral lesion.
Now the common femoral. Generally speaking, we go with an O18 V control. Yeah, I don't want to say, but. Hydrophilic O18 wire, and then we go down, and then we use a standard balloon.
Sharif Kirdawi, what will you use?
For this heavily calcified lesion, I will use an O18 wire system. But Sharif, I have to ask you some. When you're crossing the femoral lesion, what do you think? That it is totally heavily calcified, or part of this lesion was thrombotic, soft, so you can pass UI easily?
No, it was pure calcium.
Pure cat, and you passed a transluminal or subintimal?
Transluminal with an O18 wire.
Okay.
Exactly.
I will use an O18 wire, an O18 support cath for both lesions. Actually, they will give me the length and give you need the support.
Will support your wire with the catheter or with a balloon from the start?
No, with a catheter, with a support catheter.
Sharif, what you did?
In this situation, we used a support catheter, but in this stage. But at this stage, because we are coming with a long sheath coming from above, so just passing the O18 wire through the common femoral artery and followed with the balloon. The point in here is I want to talk about the choice of the size of the balloon. What do you think about a 5 millimeter balloon in the common femoral artery?
In my mind, is absolutely perfect. I mean, never stress too much a very calcified lesion.
That was the point. Yeah, that was the point. I was pretty frightened. I was freaking out because of the over ballooning or over dilatation of the femoral artery, and I understand that the profunda femoris artery is a very respectable artery, and I cannot sacrifice it under any circumstances. So that's why after passing the O18 wire, we started a very, very gentle dilation with a small sized balloon, which is a 5 millimeter in diameter. And we will see what happened next. Shall we proceed?
This is a good idea, Sharif. A small balloon for the calcified lesion, to make a track, to test the vessel, to test how this vessel can respond to the regular balloon, and you can upgrade the size of the vessel according to the result of the small balloon. Because when you passing a wire in a totally occluded calcified vessel, this is very good first step. Then upgrading dilatation of the vessel, a small balloon, 5-0 balloon, and then you can upgrade the balloon, especially in a calcified and at the area of the big profunda, precious profunda, for fear of even distal embolization of the calcium for the distal bed and also for the profunda artery.
That's what we did. We O18 wire followed by a relatively small size balloon. I mean, relative to the normal size of the common femoral artery, and we did it.
If the wire passed easily, or
with some sort of negotiation. I mean, just torquing the wire a little bit right and left, and the wire could find its way or its path through this heavy calcium without much annoyance. I mean, but it was not that hard.
Sharif, I just had a question here regarding the common femoral.
Yeah.
Wouldn't you use a Rotarex, for example, before ballooning this lesion? Just one or two passes with Rotarex, we might have some soft thrombotic materials inside going for distal embolization. Would you think that would help if you have a Rotarex in your hand?
I would be in a dilemma where to put the filter. Would you put the filter in the SFA or profunda? Because as I said, I respect the profunda femoris artery too much. I have no way to sacrifice any piece of debris going into it. So you might be right, but I didn't try the Rotarex, no.
And personally, I do agree with you, because mostly whenever, because we are moving toward something which is vessel preparation. So if you consider that there is some thrombotic component, the probability to have a plaque dislodgement during the procedure, whatever device you use, is so high that you need to find a place where to put a filter. And in this case, it's not that easy to find the right place.
Exactly. So shall I proceed with the next image? Now, after doing the dilatation, we'll get back again to the, to the common femoral. Just a second, something. Now, so After doing the dilatation, I'll show the post-balloon angio for the common femoral. But just to continue, to know the anatomical tree, how was it like? This is a support catheter. This is the tip of the support catheter, which was a laser, as far as I remember, and coming from up. And this, we were trying with the 018 wire to traverse this lesion. But as we said, in here, we tried trying from the brachial axis with us, even with a support catheter and 018 wire to try to traverse a heavily calcified lesion, sometimes might be challenging. We were trying to traverse the lesion with an air bubble in here, but we failed as well.
No.
So the decision was to go retrograde. And as I mentioned, we were preliminary before the procedure, we were deciding to go retrograde through the anterior tibial artery. And in here, as you can see in here, that's again the support catheter and an 018 wire trying to find its way from down upwards through the heavily calcified lesion. And as you can see in here, just gently, the wire trying to find the transluminal side. Yeah.
Sharif.
And this is the threading of the wire through the Bernstein catheter. Yes.
We have some questions from our colleague, Dr. Tamer Fikri. We know he's a vascular surgeon, our friend. He asked about what about having two axes from the right brachial and from the femoral one?
Left brachial or right brachial?
Just one brachial and one femoral, he said. One brachial and one femoral. You prefer something like it?
As we said at the beginning, the heavily calcified, both common femoral arteries were pretty much challenging. I mean, I couldn't even go contralateral. I mean, even the right leg, which is not the symptomatic, which is the asymptomatic leg, I couldn't go through the right common femoral artery because of heavy calcification. His femoral pulse was barely palpable because of his calcium, and with ultrasound examination, can hardly see a lumen of the both femorals. You can hardly really see a lumen.
Okay, Sharif.
So I wasn't happy to put a sheath in any of his common femoral arteries. Is that enough?
There is a question. Why not a hybrid procedure, endarterectomy for the femoral and endovascular for the popliteal?
Yeah, I think this is a valid option always to have a hybrid procedure, to do an endarterectomy for the common femoral artery and then complete your procedure with endovascular maneuvering. But still, it is not the first option. I think the first option always is total endovascular. If we fail to do the total endovascular option, I think we'll shift to the hybrid procedure. It's still a valid option, and it is always valid to have a hybrid procedure.
Okay, Alberto, if there is any data to use the axillary artery to save the lens to approach more safely to the...
No, I tell you, apart that axillary puncture sometimes is not very well accepted by the patient, but apart the point, we have to remember that you can in some way damage the nervous system nearby the axillary artery, and so I did in the past, but to be honest, today having the humeral approach is so good that I don't do it. I tell you.
I am encouraging all our people, our colleague on the webinar to share like this by their question, and we are ready to have the answer. Okay, Sharif, go on.
Okay, so just to continue answering Dr. Tamer Fikri's question again, he's saying why not to go in a sequential manner, because I haven't shown you yet the post-ballooning image. So if you can just postpone this question until you see the post-ballooning image of the common artery. Probably you will not be much enthusiastic to go through it again. Okay, after wires traversing the lesion from below and now, and after we traversed from below and we snared the wire or threaded the wire to the Bernstein from above, so we reverse our direction and coming from above again from the antigrade axis again. Because here, as I said, the traversing from the antigrade initially was very cumbersome and was very hard. But once we threaded our wire and snared the wire from the other side, we can easily shift or reverse our equipment and come from above easily. And this was tackling the.
May I ask you?
What is the catheter? What is the catheter? What is the type of the catheter you used?
The trailblazer with the O18, V18 control wire to traverse the lesion, and the Bernstein or the Bern catheter to snare or to thread the wire into it. And then when we came back from above in here, that's a 5 by 120 over an O18 wire balloon, coming to start to deal with the popliteal lesion. If you want to see, if you want to go back to see how was it, that's the area where the total occlusion was in here. So that's the ballooning of this segment, and then the ballooning of the above segment, which at the lower SFA at the Hunter's Canal and the beginning of the popliteal. And you can in here appreciate that there was pretty good amount of calcium in this area. So after ballooning, now this is to answer Dr. Tamer Spekler's again question about going in sequential manner.
What is the pressure of the balloon?
We usually I don't exceed the nominal pressure in most of the time.
For how many times?
3 to 4 minutes. 3 to 4 minutes, at least 3 minutes, maybe 4 minutes sometimes.
Alberto, when using the balloon inside some artery, this calcified artery,
you can see in here the image of the common artery after the initial ballooning. So what do you think?
Obviously, I mean, we see not a satisfactory result at just above the bifurcation, and then going down, fortunately, something not bad until the Hunter Canal, and just down there is a significant residual stenosis, if I understand correctly.
Yeah, and if I proceed with the further images, you can appreciate again what happened, because in here we started to re-balloon again the common femoral artery, the prolonged balloon inflation, and this was the result after the second ballooning for the common femoral artery. Well, it's still not completely satisfactory, but if I proceed to the next slide, to where we were having a look at the distal circulation. Can you see this? This is very significant in here at the lower SFA or P1 segment. So this was the result after the initial ballooning. And we, at this stage, we were just asking, because is the distal circulation okay? So I think at this stage, with having all these collaterals and all these going down and the posterior tibia going down to the foot, we were thinking, shall we stop?
I don't think that you can stop leaving. I mean, the inflow is.
Yeah, I'll go back again to show it. Yes, exactly. I'll just go back in with the slides to show how was the inflow. That was the common femoral artery. Okay, it's pretty much better than what we started with. Okay, but still is not, as is written here, not completely satisfactory. Okay, and again, this is
I think, Sharif, to answer your question, I think in such kind of lesions, you have to wait for some time, maybe 5 to 10 minutes, and re-angiogram it again. If you find a recoil immediately, I think
the same.
yes.
That's what we usually do, and it was the same. This image exactly the same after 10 minutes, exactly.
You have two ugly dissections, one on the common femoral
Yes.
and one in the distal SFA. I think you
Yes.
cannot leave this like that. You have to do something for both of them.
Well, that's what we should have done, but we stopped at this stage, okay? And we stopped the procedure at this stage, and we decided to follow up the patient clinic and see what will happen. And
Sharif.
that's what happened.
Sharif,
Yeah.
before this CT angio, Alberto, you will try again with high pressure balloon, long balloon inflation, and then to decide to leave this the entry point or not, or you stent this entry from the start. What
Yeah, I tell you, my position today is that we have really to look at the inflow status in a patient with really a true critical limb ischemia, because we have seen that the distality in the toe is not absolutely acceptable. So generally what we do, we can discuss about the common femoral, because okay, was not a very good final result, but I could say acceptable. What in my mind should be treated is the distal SFA and the segment from P1, P2. Probably I missed something in the P3 segment, but in my mind, I would have done a procedure, a stenting procedure in the distal SFA and the P1, P2 segment.
Yeah, the procedure actually was aborted at this stage, not only
Sharif,
based on clinical.
Sharif, if there is any rule for drug elution balloon in this situation, the heavy calcified vessel, is the drug elution after conventional balloon have any rule in this situation?
Well, I think this is this is not what I was looking for, because in this particular case, we were looking for something else apart from drug-coated balloons, because we know that the DCBs does not work very well in heavily calcified lesions. But what we were looking for, we were looking for a stent to deal with this anatomy, with these tough vessels. And because due to some logistics, it's not available at hand at this point of time, plus with this partial improvement in the angiographic picture, that's why we decided to stop the procedure at this stage and postpone any other interventions to a second stage if needed, while keeping the patient under close monitoring.
Alberto, if there is any place for the rotablation at this moment, if the conventional balloon failed to do the job satisfactory from the recoil, from the residual stenosis, we need to debulk this lesion with rotation, or we need to use the rotablation from the start before the balloon dilatation.
I tell you, look at the final result of the first procedure. I would be scared to do something in this important dissection, where also we have a lot of calcification in the vessel wall. You can have, generally we use directional atherectomy if we want really to obtain an important result, but you can perforate, you can really dislodge a lot of material distally, and is not, I'm not convinced that in that specific case is the best for the patient.
Okay. Okay.
So
if you can continue, okay.
yeah. So 6 weeks later, the wrist pain still continues. Well, actually, he had sort of improvement from the baseline pain, but after 6 weeks, he still have some sort of wrist pain, and the gangrene started to creep slowly over the base of the affected toe. His ABI was a bit better than before, but still not satisfactory. So the decision was taken again to complete the first procedure, or the primary procedure. We decided to go again retrograde from below in here, as you can see. And why? Because at this stage we were planning to use the Supera stent for these heavily calcified lesions. And because we were planning to use the Supera stent in the common femoral artery, and because I usually prefer to try as possible to limit the extent or the travel of the stent up in the iliacs, that's why I was feeling much comfortable to stent the common femoral artery from below. I know that the PRESTO technique is mainly described for stenting the ostium of the SFA, but I was thinking using this same technique with the common femoral artery might be a good idea to try to limit the upward extension of the stent into the iliacs. Any comment about that?
Why Supera stent? Why you choose the Supera stent in this situation?
Because the Supera stent has the compression resistance and flexibility, which is something that is for most stent manufacturers is a design trade-off. I mean, most of the stents has to sacrifice one of these characters for the sake of the other. If you want a stronger stent, you will have it less flexible, and vice versa. But in this particular lesions, because you have a heavily calcified lesion, so you need a high compression resistance stent, which is in the Supera. And at the same time, you need a highly flexible stent because you're going to implant a stent in the groin, in the common femoral artery, and another stent at the Hans canal, which are the most important two segments in the lower limb liable for torsion forces, stretching force, compression forces. So that's why I was thinking about the Supera in particular, if this is enough as an answer for your question.
Alberto, what do you think?
Yeah.
This is the option. You will put stent in the common femoral, in a calcified lesion, in the groin. So do you think the Supera is the best option for this case?
Yeah, the Supera, not by chance, we name Supera stent a mimetic implant. Mimetic because you really respect the original anatomy of the artery. We are speaking about the bending zones where we have a lot of calcium in the vessel wall. For this reason, the radial force exerted by Supera stent at the moment is absolutely unmatched. This is what we do for the common femoral. Consider that an important point is to preserve the profunda if you want to deliver this stent over there, any kind of stent over there. And I really wanted to see what Sharif did.
But you think the data that said Supera stent is 0% fracture? This is
Exactly.
Encourage you to use it more, because if you have a stent with from the data from the trials, there is 0% fracture. It is a very good point, I think.
Yeah, absolutely. This is another very good point in favor of Supera.
Okay.
And
So
because the SFA at the Hunter's canal is pinned with the inside its fibrous tract, it's something similar to the arch of the aorta when it changed into the descending thoracic aorta. At this particular region, at the aortic isthmus, this is the most important part of the aorta that's liable for dissections because it's a mobile part and then fixed part. So I think that the SFA as well at the Hunter's canal, it has a similar situation. The SFA at the Hunter's canal is pinned to the bone with the fibrous tissue which is around the adductor magnus. So this area of the artery is liable or subjected to very excessive torsion and rotational forces. In addition, of course, to the groin, the bending of the groin. So that's why the compression resistance and the flexibility were the two most important criteria of the superior stent. That's why we have chosen it, and that's honestly why we were not happy to proceed with stenting in the first procedure, because it was not at our hand at this point of time. Shall we proceed?
Proceed. Because we have 10 minutes, Sharif, to
okay,
continue.
I'll try to go as fast as possible. Now, this is just an image from below, angiography from below. As you can see in here, the heavily calcified all through, and in here in the second image, the wire is just fine its way in here. See through this narrow lumen up. That's an 018 wire as well, and then the wire going up to the common femoral and up to the iliac in here. Now, after that, what we are doing exactly as Professor Cremonesi was just saying, we were thinking about the profunda femoris artery. And as you can see in here, the title, securing the profunda femoris artery. That was the main issue in here, how to secure the profunda femoris artery if you are going to stent across the profunda femoris. So through the brachial sheath coming from above again, with the brachial sheath again, a wire was parked in here, as you can see in here in this image, the wire just negotiating the disease gently and then going down to the profunda femoris artery. So, and the end result in here, we have a wire coming from down upwards where the balloon is on, and another wire coming from upwards to the profunda to secure the profunda. Now, this is the ballooning from down, and in here at this stage, we used a bit larger balloon. This time, we used a 6 millimeter balloon in diameter to dilate the common femoral artery. And as I said, the profunda was secured with a wire. So post-ballooning angio, then the supera 6x80 in the SFA, in the, common femoral artery, it's the PRESTO-like technique while securing the profunda. So now, as you can see in here, the supera was deployed and wire going through it from outside to the profunda femoris artery. There was a very good flow to the profunda through the supera struts despite slight stent packing. In fact, this was our first time to deploy the supera stent. So if you can appreciate, there was a slight packing in here in vision, and in this region as well, there is slight packing if you can appreciate the packing in here. But although this packing is very close to the bifurcation, it did not affect the flow in the profunda femoris artery.
Alberto, if there is any tips and the tricks for deployment of the supera stent?
No, I mean, to be honest, it's not the easiest stent to be deployed, but you have to go very slowly. Generally, what we recommend is really to look at the stent delivery in progression, and when you see that you are packing too much or you are really pull too much on the delivery system, you have really to stop, to take time and to start again. I am not, I tell you, generally speaking, I am not very scared about the stent packing, I tell you, because because what we have seen, no, consider that where you see the stent packing, you are reaching the highest radial force exerted to the artery wall. So it's not a negative in such a calcified lesion.
Good, and one more point is that this packing in this particular point came coincidentally with the bifurcation, and despite the bifurcation was heavily packed with the stent, but still this did not affect the flow in the profunda femoris artery, as you can see.
Okay, okay, Sharif.
Now, so then we proceeded to see what's going down there. So that's, as you can see in here, that the SFA, and then that's the lower SFA in here in the middle image. That's the lower part of the FA and the beginning of the popliteal. That's the knee joint down there in this middle image. And then the remaining of the popliteal PD3 segment, and then the tibial vessels. And now, so again, we decided to deal now with the lower part, the pathology in this lower part. So this coming part is pretty interesting, because what we did is we used an Armada 18, a 5.5 by 150, and then we decided to implant a Supera 5.5 by 120 balloon in this part, the lower SFA part. As you can see, that's the Supera delivery system going up in here. Okay, and then started to deploy the Supera. And as you can see here, that's a still image of the Supera after deployment, just in here. That's the same image in here with these two markers. You can see in here, this pin, this radioepic marker demarcates the beginning of the stent. Please concentrate on this. The stent in here starts just at the pin, if you can see. But as you can see as well, the stent deployment in was not properly done. Maybe the vessel preparation was not enough in this region. That was our conclusion, why the stent deployed in such a manner. Probably the part of the vessel was not properly prepared. And that's why vessel preparation is crucial before deploying the Supera stent. So let us, what happened.
The stent from retrograde or from the antegrade approach?
That's from down, from retrograde. Okay.
From retrograde, I think if you deploy it from retrograde, shortening will be down at the P3, not at the beginning. Because at the beginning, that's not shortening.
That's not shortening. That's not shortening. That's a problem deployment. The vessel was not properly prepared in here. That's not shortening now.
This is undeployed proximal part of the stent.
Exactly. No, yeah, it's deployed, but it's not fully expanded. So just let me just go to the next slide to show you what happened. So when we saw this, again, when we saw this image, this part of the stent was not properly opening. And again, just concentrate that the stent is reaching up to the pin, okay? So what we did is I went with the balloon and did a post-stent balloon dilatation. Okay. What happened with the post-stent balloon dilatation is this shortening of the stent. The stent was reaching up to here. And after the balloon, it opened nicely, but it came to here, which is intuitive, and that's logic, because this stent, it's not struts fixed together. It's just, it behaves as one unit. So this is one point to take care of. I mean, I don't want anybody to do this problem again. Proper vessel preparation will prevent incomplete deployment. And in case of incomplete deployment and post-stent dilatation, this will lead to stent shortening. So the stent shortened and went down. And what happened after stent shortening, as you can see in here, this very ugly dissection at the top end of the stent. So after the post-stent dilatation and stent shortening, we discovered that there is a very nasty dissection in here. For this very nasty dissection, we just used a nitinol absolute 7x40 stent just to hold this dissected area. And after that, we went further down to the popliteal artery segment. And when we went to the popliteal artery segment, this time we insisted to do a very good preparation, a very good vessel preparation, and make sure that the balloon is fully inflated in here and there is no residual lesion. And after that, after good vessel preparation, this was the third Supera stent to be deployed in here. It's pretty much different than the second one and the first one. Nicely deployed Supera 5.5 by 150 after good vessel preparation this time in here. That's all. Thank you.
Thank you very much, Dr. Sharif. It's a marvelous case, marvelous teaching. We can conclude the session in some points. The calcified lesion need special preparation from the axis, the tools, the balloon, the small balloon dilatation, gradual dilatation, no overloaded balloon dilatation. Use rotablation when it is needed. For the superior stent, it's very good stent, 0% fracture, can be put in the common femoral in the knee joints. And for the preparation, prepare the lesion before put the stent. Very slow deployment of the stent is very, very important. We look for the stent, the superior stent with the bifurcation, very good result for the profunda. From the start, do the procedure in a proper manner. Complete your procedure from the start, not finish the procedure while you are hesitated about the result of still very big amount of residual stenosis, suspected of inflow dissection. So keep the inflow in a very proper way. At the end, of course, I'd like to thank our eminent colleague Alberto Cremonesi, Professor Sharif Assam, Professor Sharif Kirdawi, and also about vascular ICOM. I think it was, for me, it's marvelous meeting. I hope to discuss in the next, the distal aorta before the SFA. At the end, I wish for you and all our colleagues, the attendees, the best of luck, the best safety for the country, for the people. And we ask Allah subhanahu wa ta'ala to remove these difficulties, this tough period from the human being all over the world. Thank you again. See you later. See you soon. Thank you very much.
Thank you.
Ciao. Bye-bye.
Thank you. Thank you.
Take care.